ladies and gentlemen. Thank you so much for giving me this opportunity to talk here today, and I think this has been a very, very optimistic conference so far, and I'm sure you all feel the momentum and the optimism behind what we're trying to accomplish here. We've heard a lot of information. We've seen a lot of data. We've heard how complex the whole concept of neonatal mortality is, all the things that factor into this, and to some degree it certainly is a little overwhelming when it comes to trying to maybe dumb this down a little bit to a point where we can actually do an intervention. At this point, my role is relatively simple. I don't have a whole lot of data to show you. The primary goal of my talk is really to present the 2012 American Academy of Pediatrics guidelines that are set out for determining the level of care at different neonatal intensive care units around the country. I'm going to give a little bit of a background. I am privileged, and I feel very privileged that I've been able to work with the COIIN initiative here in Alabama. This has been a very dynamic group. There's a core group of people who truly get things done. Okay. I'm going to go through a couple of definitions, really some important definitions that sometimes can make the picture of looking into truly what infant mortality is. I'm going to talk about fetal death, defining neonatal death and infant mortality generally. I think this is important as part of our discussion later on today. And then I'm going to give you a little bit of my perspective as a neonatologist, working with these babies every single day. Dr. Wingate gave us a 60,000 foot view. I'm hoping I'm going to make it to 40,000 feet today. Normally I'm just skinning the trees. Very frequently I'm not able to see the forest for the trees, but today I'm going to try to give you the 40,000 foot view. And then I'm going to go through the AAP guidelines. Again, our role, or my role in the COIIN initiative as part of reducing infant mortality in Alabama is, as part of this whole process, relatively limited. These are the focus areas that are going to be discussed today and have already been discussed. My area of interest is in the perinatal regionalization of neonatal care, and that's what I'm going to be discussing. The death of an infant is always a tragic one. No matter who you are, no matter what level of society you are in, no matter what country you're in, the death of a child is certainly devastating. And in the United States, we have short of 25,000 infants that die each year, and that is for the overall plus minus 4 million births a year. As you've been told, but the infant mortality rate is looked at in number of deaths per 1,000 live births. Okay, so that's what gives us the number of the infant mortality. To give you a couple of perspectives, in the U.S., the infant mortality is around 6 plus minus, as you've seen it changes throughout the years, just because the what relates or what leads up to the infant mortality is highly complicated. Infant mortality in Alabama has also been a little up and down, a little up in 2012, 8.9. And I'm not going to talk about the racial disparities and all the other complexities around it. These are true facts. Infant mortality has a certain kind of media attention when it comes to the entire as a marker for the entire health of the community in many ways. Okay, the reason why this has become the case, I think, is really the women and infants as being maybe not the ones that historically have been in the center of attention when it comes to health care. Infant mortality then over the last several years has become a marker for the community health. Certainly a marker for maternal health, and obviously, of course, in the infant mortality as part of the infant and child health. Comparing some countries around the world, struggling countries, Afghanistan, for example, will have an infant mortality, to put it in perspective, around 190 to 200 deaths per 1,000 births. Some of the countries in the world who declare the lowest infant mortalities will lie around 3 deaths per 1,000. So you know, when it comes to the definitions, obviously when we talk about a death and when we talk about a live birth, the definitions are important. Okay, it's not always given. So the definition, also given by the American Academy of Pediatrics, of a live birth is a complete expulsion or extraction, doesn't sound very romantic, but from a mother of a product of a human conception, so that's a baby, irrespective of the duration of the pregnancy, and that's very important, okay? There are some guidelines when it comes to what you have to report, which are different from state to state. In Alabama, you have to report a live birth per this definition if you've gone beyond 20 weeks gestation, okay? And how do we assess life? We assess life in such a way that the baby should have a heart rate, it should have some kind of respiratory efforts, or it can have some kind of movements resembling what we perceive as life, okay? We do know as clinicians or neonatologists or anyone who works with this definition is not always easy. And in the media, we have struggles about defining life all the time. Certainly in this population it can be difficult and things happen very, very quickly. So you can see that this area is an area where we sometimes can have some discrepancies when it comes to defining a live birth, okay, from different countries, from different states, okay. We do know that early fetuses or infants, say 24, 20 weeks gestation, will have some form of cardiac contractility, will have some spontaneous movements, and our bodies are formed such that the muscles around our thorax are designed to such a degree that when we actually use them, it will look like a respiratory effort, okay? So those definitions are certainly not always easy. Okay, and the OBs will tell you that they will assess for life in a baby that had been given by a natural process of birth at 20 weeks gestation. Okay, so that adds to the complexity, as you can imagine. What is a fetal death? Okay, a fetal death is the death of a fetus before the complete expulsion or extraction, or without extraction of the fetus. Okay, that means that the baby dies before the extraction and is then born without any signs of life that I mentioned earlier. We do not have any cardiac contractility, we do not have any respiratory efforts, nor do we have any purposeful or any movements at all. For statistical purposes, these deaths are divided into early and late. Okay, the early fetal deaths are between 20 and 27 weeks gestation. The late are after 28 weeks gestation. The term stillbirth, which is often frequently used, often describes fetal deaths at 20 weeks of gestation and later. Okay, and fetuses that die in utero before 20 weeks gestation can often be categorized or referred to as a miscarriage. Okay, these are some definitions that are important. Infant death, what is it? Infant death means that you need to have had a live birth. So at any level of gestation, if you have a baby that was categorized as a live birth, if that baby at some point dies before his or her first birthday, that's considered an infant death. Okay, we further divide infant deaths into neonatal deaths, okay, which you will have a neonatal death if you die within the first 28 days of life. You will have a early neonatal death if you die within the first 7 days of life, and you will have a late neonatal death if you die between 7 and 28 days of life. Okay, this is important for us because people die from different things, or babies will die from different things, and this will help us categorize the area that we need to work on when it comes to the pathological process that leads up to this baby's death. Okay, a post-neonatal death is after 28 days of life and up until the baby's first birthday. Perinatal death is not a reportable entity, and there are different definitions around perinatal death. Okay, perinatal death is often referred to sometimes or talked to loosely as part of infant mortality. So I thought it might be prudent just to go through the three most important or frequently used definitions. Okay, definition number one includes infants that die before the 7th day of life, but were after the 28th week gestation. Okay, so that goes from 28th week gestation up until 7 days of life. Definition 2 is a little more inclusive. It includes babies that live until they're 28 days old or die within 28 days and are older than 20 weeks gestation. So it's a larger span, okay, of the period. And I think the second definition is the one that we tried to focus on and using because it's more inclusive, okay? And I think the World Health Organization actually uses the first definition. And the definition number 3 includes infants that die within 7 days of life and after 20 weeks of gestation, okay? So right in the perinatal death definition, there might be some discrepancies. When it comes to the definitions of actually infant death, neonatal death, those are quite well defined. If you look, you've seen a lot of graphs, you've seen a lot of data today, but I'm going to give it to you from my perspective. Infant mortality rates have certainly declined over the last 50 years in the United States, and you can notice the discrepancies here between African Americans and whites. It's important. My question is, why do babies die? Okay, and what can we do about it then, obviously? The areas that I focus on as part of working in an intensive care unit, I look at the areas where I can make a difference, okay? We're looking here at the congenital malformations is a large group of, or large reason why babies die. Short gestation or low birth weight, or certainly a combination of the two, is another reason why babies die. And maternal complications. I would probably say that the maternal complications will likely affect the two that I mentioned in the beginning, but again, these are the areas that we can focus on. When it comes to congenital malformations, what are we talking about really? We're talking about anything, any form of malformation. We can talk about kidney disease, missing a kidney, you can have cystic kidneys, you can have abnormal intestines, you can have an intestinal tract that does not hook up, you can have malformations of the brain, you can have hydrocephalus, you can have spinal problems. These are all malformations. You may not necessarily die from that malformation directly, but it puts you at higher risk for dying secondary to other complications because of that malformations. These malformations are not always, but frequently associated with genetic problems, okay? And often we see multiple congenital anomalies together as a clinical entities. The preterm labor, of course, there's a level of, if you want to be realistic, you want to say that an infant or a fetus will be viable around 24 weeks gestation, okay, and above, and that's when we start seeing the improved survival. Not infrequently, or almost as a standard of care, do we now resuscitate babies down to 22 weeks gestation, okay? So there's a big, large gray zone right there. If we look at the birth rate and infant mortality, we do see that there is a large gap in the less than 1,500 gram birth weight range. So right here, you see this is from 1950 to 2008, the trend is about the same. Here you are, 1,500 grams, and below you see there's still high level of infant mortality in this group. Even though if you were in 1950, you had a 10% of survival if you were less than 1,000 grams. Now you have a 60% chance of survival, okay? But still, you have a 40% chance of not surviving, so that is a large portion of our area of our infant mortality that we want to focus on as part of this perinatal regionalization. And that's the area of interest right there. Okay, so where does this perinatal regionalization come from? What is the background really? Okay, I sometimes use the example, some degree, you love your primary care physician, okay? She's been with your family for years, she's taking care of you, your parents and your grandparents, and always done the right thing for your family, okay? When your father was admitted to the local hospital with pneumonia, she was there with IV antibiotics, and the nurses were wonderful, everything worked out well. You avoided intensive care, the pneumonia went away, and the family could be with you at the local hospital, everything worked out well, and you went home, okay? A couple of weeks, or your father went home, a couple of years maybe later, you're diagnosed with a brain tumor, okay? That brain tumor should not be taken care of, and you will not expect that brain tumor to be taken care of in the same hospital setting as that pneumonia. Okay, and that's a little bit the same thing with our prematurely born babies, and some of our prematurely born babies or other infants with very complicated anomalies and problems. Okay, in that sense, in '76, the March of Dimes recognized this, that the prenatal care was so very important for the survival of the babies and overall the health of the mom, that they started a neonatal ranking system for neonatal intensive care units. Okay, that basically said, what do these neonatal intensive care units, what should we expect of them? What type of equipment should they have? What type of training should the people working there, the nurses, the physicians and such, when it comes to providing the optimal care for the babies in that settings? Okay, that was really the start of it. And levels started coming in. Studies were, as we had started getting these definitions more set, we were able to do more studies looking at the outcomes from the different neonatal intensive care units, looking at discrepancies in the level of care and overall outcomes. In 2004, the American Academy of Pediatrics, which is kind of the spokes organization of all pediatricians, which includes certainly the neonatologists in the country, came up with some new guidelines because they felt as though they needed to come into the arena when it comes to defining neonatal levels of care. These were the first levels, and they divided the neonatal intensive care units into 3 levels. Okay, level 1, 2, and 3. Level 2 and 3 were subdivided into A and B, and level 3 was even divided sometimes even up until D. Okay, and level 1 centers provided basic neonatal care for healthy newborns. That doesn't mean that they don't have any facilities available. That means that they are trained specifically in taking care of newborns. Okay, they're also trained in resuscitating term babies who have problems in the transition of being a fetus to an infant. So there's training and there's expertise expected in the level 1 unit. Level 2 at that point took care of babies 32 weeks really, plus minus need for the ventilator. And level 3 were larger ICUs with a heightened expertise when it comes to the extreme premature babies, and also a need for things like cardiac surgery, ECMO, and higher level care. Based on these guidelines, both from the March of Dimes and up until the American Academy of Pediatrics, we started gathering some data. And I'm just going to show you what this data truly tells us. So from 1978 up until 2010, there was a meta-analysis done in 2010 looking at the outcomes of very low birth weight infants born at level 1 or 2 versus level 3 neonatal intensive care units, okay? This was published by Lassville, and he reviewed whole 41 published papers, okay? Majority of these papers were good quality papers, and they looked at greater than 113,000 babies, okay? So this is our highest level of evidence when it comes to looking at therapies and interventions that actually make a difference, okay? Looking at this meta-analysis, they found that very low birth weight infants that were born at level 3 neonatal intensive care units had a 62% increased survival rate than babies born at level 1 or 2, okay? Again, in just different terms, adjusted odds ratio is 1.62, so almost twice the likelihood of surviving if you were born at the level 3 neonatal intensive care unit. This is for the very low birth weight infants. These are less than 1,500 grams. If you look at the extremely low birth weight infants, babies that are less than 1,000 grams, you see very similar findings. You have about a adjusted odds ratio of 1.55, so 55% chance of increased survival if you were born at a level 3 neonatal intensive care unit versus a level 1 or 2, okay? When they wanted to really look at the data, took out some of the studies where there was some noise, some definition problems, and maybe suboptimally organized, maybe smaller numbers and such. When they only looked at the higher quality studies, they found the same thing, 60% increased survival at the level 3 neonatal intensive care units. I think it's important to specify this, that this doesn't mean that the people who work and spend their long days and nights at level 1 or 2 level hospital NICUs do not have the right intention to do the right thing. Often their infrastructure is lacking, okay? Similar to your general practitioner who would then be expected to do brain surgery at the local hospital. That's not something we can expect, okay? And I can only take care of the babies as well as I can when I had the infrastructure around me, and that's what's important to note. These are, again, pictures of the meta-analysis looking at the trends towards improved survival at level 3. The first one was for very low birth weight infants. This is for extremely low birth weight infants. This prompted then again in the late, or in between probably in the 2000 to 2010, 2012, we had the structure of the American Academy of Pediatric Neonatal Intensive Care Guides, but we did see smaller NICUs popping up around the country. We did start to see some beginning de-regionalization of neonatal intensive care, and we started to slightly see an increase in infant mortality, believed partially of some of the things that have been discussed earlier, but also the early elective C-sections of sort of babies that are almost term but not quite term, okay? So the 34 to 37 weeks gestation babies. These can sometimes be quite difficult to manage. They can sometimes fool you in different ways, okay? And that prompted the American Academy of Pediatrics to again sit down and come up with new guidelines for NICU to increase the awareness and maybe clarify a couple of terms. And that's what I'm going to present right now. Who are the people on this committee? This is the Committee on Fetus and Newborns. These are the big hitters are really Luann Papil out of Albuquerque, New Mexico. She's been part of the Neonatal Research Network for years and has a lot of publications on outcomes in general, very well respected. And my own boss, Wally Carlo, who many of you know, who over years have had very, very good outcomes of extremely low birth weight infants at the University of Alabama. And then Richard Paulin in New York, who has superb outcomes when it comes to lung health in extremely immature infants. This is the group, very dynamic group. Obviously, bipartisan, nothing, no hidden agenda here, and they came up with these new guidelines. And these are the guidelines that I was asked to talk about. Okay, so I'm here. Level 1 nurseries are well newborn nursery. Okay, they provide neonatal resuscitation at every delivery. Okay, they are able to evaluate and provide postnatal care to stable term newborn infants. Okay, but they should also have the ability to stabilize and provide care for infants born somewhere between 35 and 37 weeks gestation, who still remain stable. Okay, and as part of this, very important, is the evaluation. Okay, the evaluation to be able to pick up any baby that may be in distress or may be in early distress, and be able to move on to an appropriate level of care. And if they do notice that a baby is in beginning distress, they should be able to stabilize a newborn, either a term baby within their realm of practice, or if they happen to get a baby that's less than 35 weeks of gestation prior to discharge or transferring to a higher level of care. The provider types that are expected to be at a level 1 care facility should be pediatricians, trained in neonatal resuscitation and assessment, family physicians, nurse practitioners, and other advanced neonatal practice registered nurses. Okay. Level 2 is now considered a specialty unit. The capabilities are considered to be babies that are born greater than 32 weeks gestation. Okay, and you can imagine the responsibility truly that's on a level 2 neonatal intensive care unit, because you saw the numbers earlier, the large infant mortality amongst the patients that are between 32 and 37 weeks gestation. Okay, so this is a very the burden of responsibility in these neonatal intensive care units should be felt. These babies then will be greater than 1,500 grams, and the providers should be able to provide mechanical ventilation for 12 to 24 hours. Okay, before the level 2 from the 2004 guidelines divided them up to A and B. Okay, now we have 1. So a level 2 neonatal unit should provide neonatal ventilation. Okay, that means that they need the ventilators, they need the capabilities of intubating the babies, they need a blood gas machine, they need portable x-rays. Ultimately, they should also be able to stabilize infants born before 32 weeks gestation. Okay, I mentioned the equipment. When it comes to the stabilizations of babies that are early, obviously this is very important. Okay, because we all know that the initial few minutes of life, the initial 5 minutes, 10 minutes, 20 minutes, half an hour of life can be very important to the overall outcome of the baby. The type of providers that will be acceptable at this level of care should be pediatric hospitalists, okay, who may or may not be on 24/7 in-house call and always be there. There should be neonatologists available. Often what happens is that there might be a hospitalist that's actually in the unit. Not seldom will neonatologists cover several level 2 neonatal intensive care units, okay? But they can also have, or should also have, neonatal nurse practitioners. Level 3 NICU, keep in mind that these 2012 guidelines actually have 4 levels rather than 3 levels. So level 3 NICU is a subspecialty, highly specialized NICU, where they provide care, comprehensive neonatal care to all babies less than 32 weeks, so all gestational ages, okay? And that includes respiratory support, cardiovascular support, and they also need pediatric subspecialties. These pediatric subspecialties do not necessarily need to be in-house, but they should be available somehow. Okay, and the subspecialties that are of course important are pediatric cardiologists, pediatric nephrologists, whatever you may need when it comes to specialized care of both premature babies, but also babies with multiple congenital anomalies. You would also need surgical specialties, pediatric surgical specialties, and for any kind of emergent surgery, unless you choose to send babies on for those specific needs. However, it should be available on site. Pediatric ophthalmologists, of course, very important for our premature baby population to rule out and follow for retinopathy of prematurity, which you may or may not know is a leading cause of blindness in the Western world. Again, level 3 should have provide full range of respiratory support, include different types of ventilators, the use of high-frequency ventilation, and nitric oxide, which is used as a therapy for term babies with special breathing problems. They should also have the following imaging available for acute imaging and acute reading and getting the data back to the clinicians as soon as possible. These are the provider types that are expected to be in the level 3 NICU. That means that you have a neonatologist who round on the babies and see the babies every single day, okay? And you will have a wider range of subspecialties available, pretty much all pediatric subspecialties available to the infants, okay? The difference between level 3 and level 4 is this, that level 4 NICUs will provide ECMO, extracorporeal membrane oxygenation, which is used both for either for cardiovascular collapse or for respiratory failure. Level 4 NICUs will also provide cardiovascular surgery and cardiovascular services. Level 4 NICUs will then have the following subspecialties and pretty much anything that you would expect to be at such a level. Okay, but the big difference here on this list will be the cardiovascular intensivists, the cardiovascular surgeons, the pediatric cardiovascular anesthesiologists, and ECMO specialists. The perinatal regionalization that we've started here now in Alabama, I'm going to quickly give you a couple of numbers on what we've managed to do so far and what we've actually discussed. The goal of the 2010 World Health Organization Healthy Peoples Act was really that 90% of infants should be born in a facility that meets their level of care as need. In Alabama currently we're at 86%, at least that's the last number that I have, so not too far off. But it's intriguing to look at the numbers and see actually where we do fall behind a little bit. The percent of very low birth rate infants by level of care from 2007 to 2010, you see that, interestingly, 10% of babies that are less than 1,500 grams are still born at a level 1 hospital. Okay, it seems to me as though the level 2 hospitals realize that they're going to get themselves in trouble understand the complexity and send these babies off. Level 1 are probably the providers that have these mothers come into them and just deliver. Okay, not that they choose to deliver extremely or very low birth rate infants, but as part of looking at these numbers, it becomes apparent over time where the need is in the community in order to be able to get these pregnant women when they're in labor to the right places. Similar picture, around 200 babies less than 1,500 grams were born at level 1 centers in this time range. We're starting to accrue some information and looking at some hospitals. Again, this is a slide that I borrowed from one of our conference talks. Just looking at different hospitals. Why are they receiving these babies? And why are they actually choosing to deliver them? It's probably a service that they're providing. I think no one is doing this intentionally, but how can we make this different? Okay, how can we change? Because based on the numbers before, the outcomes are important. at this point, I guess I want to thank everyone for listening, and and we'll continue on our discussions. And I appreciate everyone. I appreciate COIIN and what you're doing so far. And over time, we'll work with the Alabama Hospital Association, and we will ask each hospital ultimately to be able to declare their own level of neonatal intensive care unit that they want to have. Okay, and then we'll work with the hospitals. We'll work with the transport and referral patterns, and optimize and make sure that babies are born at the level of care that they need. Okay, wonderful. Thank you very much.